Good afternoon, everyone, and welcome to today's webinar on thyroid disorders and obesity. This webinar is presented in collaboration with Reem Hospital. Today's session will cover key insights on the common thyroid disorders, the importance of early detection, the relationship between obesity and thyroid disorders, and treatment and management options. Please note that there will be a Q&A session that will follow this presentation. So feel free to prepare your answers and submit your questions, and we will address them at the end of the presentation. Without any further ado, let me now introduce our speaker, Dr. Aly Khalil, consultant endocrinologist and head of department at Reem Hospital. Dr. Khalil, over to you. You may now share your screen in order to begin the presentation.
Can you see me well?
Yes, your camera is on.
Yeah, thank you very much. Thank you, Fatma. Thank you for Daman for asking me to give you a talk on a quite challenging and interesting topic, actually, obesity and thyroid disorders. So let me first highlight the objective of what we'll be covering in this talk. One, to understand the link between thyroid disorders and obesity, and explore mechanism of thyroid hormone influence on metabolism and weight, and discuss clinical implication and management strategies for obesity and thyroid disorders. So I'll try to simplify things really as much as I can. Let's first give you an overview, really, how frequent thyroid disorders in the general population, how prevalent they are. Thyroid disorders in UAE, there has been a recent study, is in the range of 19%. But when we talk about overweight and or obesity, the number goes a lot higher, it's in the range of 60%. Now, this really implies the significance of those disorders in the population, highlight the importance to highlight define whether there is any relationship between thyroid disorders and obesity. And for this, let me start by highlighting, it's a little bit complicated slide, but I'll simplify it. Just to mention the role of thyroid hormone. Thyroid hormones are, as you know, secreted by the thyroid gland, which is by itself controlled by the pituitary gland. So there is a feedback mechanism that's really very active in this regard. They are essential in controlling our basal metabolic rate. What we mean by basal metabolic rate is the amount of energy needed for our basic life function, like breathing, okay? And when we rest, at rest, what the body is needing as far as really energy to maintain the ongoing and continuous function in the body. And their action is basically they are the center for the major element to control the thermal generation. And this they do this through specific element in the cells called mitochondrial elements, where the energy is formed in the form of a special molecule called ATP, and which are used in the what we call the obligatory type requirements that we need on a regular basis. And that's why we call that when we talk about thermal energy that's really generated by our body, there is some part of that thermal energy is necessary on ongoing basis, and the other one is adaptive. What we mean by adaptive is like when we are exposed to cold, we need something that really is faster, takes less time than the usual way of forming and ATPs, those molecules that preserve energy. So we need something that acts very fast and bypass this pathway. And this is done through mobilization of fat cells during a type of fat that we call brown adipose tissue, which is found mainly in all human beings, as well as in animals. It's a type of fat that's present mainly around the shoulders and the neck, and is really the one that we use for in concert with the central system, like the sympathetic system, to generate heat when we are exposed to cold. So we don't have to go through shivering, okay, which really happens to mobilize skeletal muscle when we need to generate energy at other times that cold exposure. Now, the issue here is what is more important as far as really balance between weight gain and then mobilization of thyroid hormone. Is the obesity basically affecting the thyroid, or the thyroid disorders are affecting the excess weight that really is accumulating? The overall impression is that effectively is the obesity that generate the thyroid dysfunction or dysregulation of the lack of proper production of thyroid hormone. And this is done through different mechanisms. One is what we call peripheral, and the other one is central. Central being at the level of the brain, the hypothalamus and the pituitary, and the other one at the level of the periphery, mainly the adipocytes, which are the fat cells, and the skeletal muscle. It looks like there are receptors at the level of the skeletal muscle and the fat cells. Those are essential for getting message from thyroid hormone to mobilize fat cells. And it seems that the number of those receptors is downregulated, and that's really what happens because of the excess message sent by hormones secreted by the fat cells, called one of them essentially called leptin, that affect the production of TSH and thyroid hormones. So having said this, in case where we have underactive thyroid gland, the question is here is hypothyroidism. Does hypothyroidism causes weight gain, or this is something unrelated? Well, there is weight gain when we get hypothyroidism, and this is because of decreased metabolic, the basal metabolic rate, like you're not generating energy the same way that you need to. Actually, that mechanism is down-regulated by 40%. And there's other tissues that involved with that. There's less mobilization of sugar from the liver. There's more accumulation of fat in the cells. And the end point is what we call now, is very commonly known as insulin resistance. And that insulin resistance is one of the key elements in enhancing insulin secretion and accumulation of fat in the fat cells. The other element is that in hypothyroidism, there is decrease, surprisingly, there is decrease in appetite. And this is because of some mechanism that happens at the level of the central system, but this is compensated by decreased energy expenditure. The endpoint is weight gain. In hypothyroidism, where there is excess thyroid hormone, this is basically different. Instead of having downregulation of your own basal metabolic rate, there is upregulation. There is more energy expenditure. We need more energy because the thyroid hormone stimulate needs more heat generation and cause more mobilization of. They need more sugar. They need more fat to get the energy from them. And that's what happened with hyperthyroidism. And then instead of having weight gain, we have weight loss. And the estimated weight loss is in the range of 65% of the patients are seen do experience weight loss. However, there is still 10% of the patient may complain of some weight gain. And this is not because of the lack of the thyroid hormone action, but rather because they keep eating more. And then the balance between energy expenditure and the needs of the body really is more in favor of weight gain. So there's another category, what we call subclinical hypothyroidism. It's the stage where people might feel a little bit tired, a little bit fatigued, but when we do thyroid function test, the basic thyroid function test known as free T4 and free T3 are normal. The only one that really is abnormal is there is an elevation in TSH. TSH is the glycoprotein that's produced from the pituitary cells. And that's why we call it subclinical. It means that there are no clinical symptoms, but when we do the blood test, there is some derangement in the blood test showing that the baseline thyroid function tests are normal, but the TSH that regulate the production of thyroid hormone from the thyroid gland is elevated. And this is also has been shown to maybe affecting also heat production and maybe favor the some weight gain. Now, how do we manage usually underactive thyroid, which is hypothyroidism, is by using a drug called levothyroxine. And the idea is that whenever we use, and with patients that I see in the clinic, then I want to tell them that we start taking the medication, they would expect some significant weight loss. In fact, this is not the case. The effect of thyroid hormone is not as prominent as our own thyroid hormones. It does replace and correct some of the symptoms, but the impact on weight is not as pronounced because it only work on mobilizing some of the water retention that happens with underactive thyroid. And the expected weight loss that we see when we replace someone with endothyroid gland is not exceeding maybe 3 to 4 kilograms. And this sometimes causes a little bit of dissatisfaction from the part of the patient. While we're taking medication, we're still feeling a little bit tired, we're still gaining, we haven't lost significant weight, we're still feeling excess weight. What to do with this? And this is really here what now lately we have been talking about, that nothing replaces your own thyroid gland. And maybe that T4, the levothyroxine, which is the drug that we're using, is not enough to provide all the needed elements to address all the consequences of underactive thyroid. And we have been talking about combination of two drugs like T4 and T3. I can answer I'll elaborate on this topic maybe in the question and answer session. So we have to be realistic when we're dealing with treatment for underactive thyroid. Now, the weight gain sometimes we see also in cases where they are overactive as far as thyroid hormone production. And why is this? Because now to treat overactive thyroid gland, what we need to do is to give medication that block the secretion of thyroid hormone. So when you have less thyroid hormone, you have less energy use, you have tendency to gain weight because now you're not using as much calorie as much as you're supposed to do. And that's typically what we see when we treat overactive thyroid. We have three ways of treating overactive thyroid gland. One is using medication, we call them anti-thyroid medication that block the secretion of thyroid hormone from the thyroid gland. Or we give them radioactive material that have iodine in it. It gets into thyroid, the radioactive material hits the cells, active cells, and destroy them. The consequence of this is underactive thyroid gland. Or we take the thyroid gland out completely, so there's no thyroid produced by the thyroid gland. And the estimated weight gain after treatment for overactive thyroid gland is estimated between like maybe 5 to 7 kilograms. And some actually gain even more weight, especially if they are treated with radioactive iodine treatment. And the reason is, as I mentioned, is the transition from a hypermetabolic state to a hypometabolic state. So we're not utilizing the energy, and there's more increased fat storage. Now, what about bariatric surgery? Now, bariatric surgery is one way to treat obesity, and especially morbid obesity or obesity associated with other morbid conditions like diabetes or high blood pressure or hyperlipidemia. Well, if you take someone who's been defined by obesity, and we define obesity under specific terms by taking height, and weight and measuring what we call BMI. If the BMI is more than 30, we call them obese. If between 25 and 30, we call them overweight. And between 19 and 25, this is normal BMI. So if they are obese and we do thyroid function test, surprisingly, some patient will have abnormal function test, thyroid function test, in the sense the TSH will be elevated and patient will come, well, I have something. This is what explained really my weight gain. And interestingly, this is because of the obesity itself, not because of something wrong with the thyroid itself. The obesity and the fat cells in the body secrete some transmitters that really go into the blood, affect the central compartment, and cause derangement and resistance to the thyroid hormone that our body is producing. And the resulting also on the metabolic side is hyperinsulinemia, which we call it insulin resistance. And interestingly, when they go to bariatric surgery and they lose the weight and we repeat the thyroid function test, those get back to normal completely after the weight, even after 5 to 6 kilograms of weight loss, the TSH, if repeated, will be normal without the need really for resorting to any type of therapy. And the way that we address now obesity is two different elements, and either we resort to lifestyle intervention, or we use some medication, or now we use bariatric surgery as a mean of really addressing obesity. And why I'm getting to the treatment section is that some of the treatment we're using, some of the diet that we're using can affect the thyroid status itself. For instance, we have different type of diet. You have heard about them. We have the Mediterranean diet, which is a diet that is rich in vegetables, in fruit, and grains. This has been shown to be very effective, not only for the thyroid, but also for the cardiac status, because for patients who have cardiac issues, it was felt to be the best diet to resort to. And this type of diet, it means that a patient have underactive thyroid on the basis of inflammatory changes within the thyroid, something we call thyroiditis. It seems that the Mediterranean time see improving the inflammatory status that we see sometimes with obesity. Inflammation is one of the elements that really also is implied in the way that we have thyroid dysfunction. The paleo diet is basically the keto diet. It's basically resorting to a diet that our ancestors used to use before, where milk product is not there present, refined sugar is not present. All what they use is mainly the animal element meat, animal fat, and then vegetables, and then fruit. And some of these studies recently, although small studies, I found out that the paleo diet could affect the inflammatory process that can happen within the thyroid, either in the underactive thyroid or in the overactive thyroid. Obviously, aerobic and resistance training also can improve the lipid profile if we're having some abnormal lipid profile, and reduce the secretion of the hormone coming from the pituitary called TSH by itself. By reducing TSH, that will affect the function of the thyroid gland. Nothing really, it's nothing without really understanding the fact that behavioral therapy like motivational interviewing and cognitive behavioral therapy also enhance adherence to any type that you put patient on. You have to convince your patient that what you're asking them to do is for their own benefit. And this is really where a good interaction between the physician and his patient is really essential. Now, to lose weight, but it's estimated that you need to have a negative balance of at least 500 kilocalories per day. Now, how can you achieve this? If you want me, I can go over this, but this is an overview for you. You can take a picture of that, and then maybe you can put it on your training machine when you get on the if you want to do some exercise or see what how do some changes in your diet. For instance, if you skip uh, one snack on a daily basis, you can estimate that your loss will be between 150 to 200 kilocalorie. If you opt for small portion and avoid second servings when you're eating, you can estimate that you can get like between 100 to 150 calories saved. If you do brisk walking for 60 minutes, this will be equivalent of 300 to 400 kilocalorie burn. If you jog, it's almost the same for 30 minutes, so less time. If you jog for 60 minutes, that will double. So it will be between 600 and 800 kilocalorie. If you combine the reduced calorie intake and then you do exercise, obviously it's additive, so you can lose more calories. And so this is to give you an overview how you can achieve that 5% negative, 500 kilocalorie negative balance. High protein and anaerobic exercise, high protein, adequate protein intake, it seems that you have to consume enough protein, which is estimated at 1.3 gram per kilogram per day, to maintain, to support your the muscle gain that you need to preserve if you're doing exercise. Training resistance exercise is mainly like weightlifting, body weight, is to maintain and build muscle mass. But but if you want to do like resistant training by weight lifting is more like anaerobic exercise. That will be also beneficial for muscle balance and muscle build up rather than the aerobic exercise, which is mainly for calorie waste. Obviously, if you combine both high protein and exercise, the benefit will be better achieved. So now one of the also element that really we have to keep in mind is that if we use now, there are some medication that patients with diabetes do use, and do those affect, do they affect the thyroid? If you do blood testing, would they affect the type of blood profile that you get? They do. Some of them they do. And for your own really interest, I included those different medication we're using. How much time I have? Still okay?
Yeah.
Yeah. So there's some different drugs that have been used. You have the what we call the Xenical. Some of you have been using for obesity. It's mainly what it does. It's a drug that gets into your bowel and small bowel and binds pancreatic and stomach enzymes and prevent the probably digestion. So there's delayed digestion of fat, mainly fat, and that's really it's seen in the in the stools basically. So this is the type that really can work and can reduce your weight by 8 to 9%. But this is not advisable really for instance, taxi drivers. If some of you are really or getting into some taxis with drivers taking this type of medication, because if they don't watch their diet, they need excess fat. Because of the lack of those enzymes, they cannot retain, and they have a nerves to go, and they can sometimes they can spoil themselves. So the consequence is a little bit embarrassing sometimes. The GLP-1 receptor agonist and GLP-1, those are type what we call incretin agonist, which they enhance the insulin secretion. They are products that come from the stomach, and they are isolated and then given in the form of injection. And they are given now, lately they're giving in the form of injection weekly. We have Ozempic, which is well known for all of you. It's semaglutides, and we have the combination of GLP-1 analog and GIP. It's under the norm of tirzepatide or Mounjaro. Both are known to enhance insulin secretion. They reduce the glucagon, which is the hormone that counteract the effect of insulin by raising blood sugar and enhancing the secretion of glucose from the liver. The weight loss estimated there is 15 to 20%. And then now that's on the market now, you can see it now, phentermine and topiramate, and under the name Xemia. This is again working on the central nervous system as a norepinephrine agonist and glutamate antagonist. Basically, they decrease appetite. And the estimated weight loss on this is 6 to 8%. This drug is controlled drug. It cannot be given by a regular family physician, and it has to be basically it's given by family doctor, but it's a controlled medication. So we have to apply to it through the proper system. And the one that can and the last one is Contrave, which is a combination of medication also acting on the central centers really to decrease appetite. But this one weight reduction is in the 6 to 9%. The one that really affect thyroid hormone is obviously Xenical, because if you take it, if you're on medication for underactive thyroid and you take Xenical along with your thyroid medication, the absorption will not happen. So you're going to lose your thyroid medication and you're not going to have controlled thyroid test. GLP-1 don't seem to have really too much effect on the thyroid gland itself, but with weight loss, every time the weight loss and if patient on medication, the medication for thyroid in the form of thyroid hormone, we give it based on the BMI, as I told you, based on the weight, basically. So if you lose your weight, your requirement is going to be less. So you need to be aware that when you take GLP, or you take Mounjaro, for instance, and you lose significant weight, your thyroid function are going to change, and you're going to have symptoms of overtreatment if you don't adjust your thyroid medication. Phentermine and Xemia, not so much really affecting thyroid hormone, the same for Contrave. So that's why I put them here, although they are treatment not related to the thyroid gland itself, but they do affect you one way or another if you're on medication for thyroid hormone. Now, the question now about, and I'm sure one of you is going to ask me, is now if you're using Ozempic or Mounjaro, is there a risk for inducing thyroid cancer? And this has been in the public, and then a lot of patients come, actually most of the patients we see now, they have been seen by their family doctor and they ask for ultrasound, neck ultrasound. And incidentally, they found they have nodule, and at times they found some nodule that really are suspicious. And the question here, can they use those injections like Mounjaro or Ozempic? And the alarm came from initial animal studies where they used 20 to 30 times the dose of hormones that we use, incretin that we use normally now on a regular basis. And they found that there's a type of cancer called medullary cancer that really the incidence is higher in those animals. And there is a recent French study that was published last year, 2024, and they look at patients who are diabetic and were treated with those injections versus other type of patient who were treated by other anti-diabetic medication, and they found a 46% increased risk of thyroid cancer, especially of the medullary type. So there was fear in the public and the physician that maybe we have to be alerted and we have to do ultrasound. And but recent study by the Scandinavian country and a recent meta-analysis that was done recently and published by the American Thyroid Association and adopted by the American Thyroid Association, our fear have to be minimized. The alarm is really very minimal, and there's no reason to be alerted. Those drugs can be used. There's no need to be on a regular ultrasound of the neck done on a regular basis. And the only contraindication still persistent, if we have to look if the patient has a history of medullary type of cancer. This is a special type, very rare type of thyroid cancer. If the family member has one of those type of cancer, this is a firm contraindication for the use of those injection. I'm almost there. This is the study. I will not go and bother you with this. And the key findings, the conclusion, GLP-1 receptor agonists, which are those type of injection, are not associated with increased thyroid cancer risk in the short term. Long-term study are needed to assess cancer latency effect. So although on the short term, there is no increased risk, but we have to be alerted that we have to follow your physician and be alerted of the possibility that might happen. And bariatric surgery, there's, as I mentioned, the requirement really come down after bariatric surgery, and this is really well established. So once you got through bariatric surgery, you need to have frequent monitoring with thyroid medication. So to take away messages, thyroid disorders significantly impact weight management if you're dealing with hypo or hypothyroidism due to their effect on metabolism, on your appetite regulation, on your body composition. Hypothyroidism, which is the underactive thyroid gland, and the most common cause being here now is Hashimoto's thyroiditis, which is an inflammation of the thyroid, often leads to weight gain, while hyperthyroidism can cause weight loss, but also can result in post-treatment obesity because of the medication we're using to treat this hypothyroid condition. Effective strategy like lifestyle intervention, diet and exercise, treatment and drugs and severe cases, bariatric surgery are needed to approach those conditions. And it goes by itself that we need to have a patient, a physician, and some people assessing the physician to make it a proper decision to optimize the issues and the outcome for patients with thyroid-related weight challenges. Thank you very much. I think I kept on time. Yeah.
Thank you very much, Doctor. You really shared a lot of informative information and very detailed presentation. Thank you for that. Now, I would like to open the floor for questions. So just a reminder, whoever has any question, please leave it in the Q&A section, and we will try to cover as many as possible. Okay, let's start off with the first question. You talked, Doctor, about obesity and thyroid dysfunction and how thyroid dysfunction can lead to obesity. Can it be the other way around? Can obesity be the reason why someone has any kind of thyroid dysfunction?
Yeah, that's what I tried to put it in the beginning of my talk. That actually now we believe that obesity can affect thyroid function a lot more than what thyroid condition can affect the weight changes. And the reason is that, as I mentioned, with weight gain, the fat cells are made in a way to secrete some what we call them transmitters or messages that affect the central mechanism that regulates the thyroid gland secretion. And the end point is that there is derangement in the way that thyroid is being secreted. So the changes we see are secondary to the obesity itself, to the fat cells itself, themselves. And also there is some receptors on the fat cells that make it in a way that they don't respond as well to the thyroid medication that's secreted normally by the thyroid gland. So the effect is less. So the end point is obesity is more important than the thyroid dysfunction. And this is the reason when we see someone obese and with no obvious thyroid pathology, but they have derangement in the thyroid test, that we put the emphasis on losing weight and then watching and repeating thyroid indices. And with time, we realize actually when they lose weight, the thyroid indices they go back to normal.
All right. So would you advise, doctor, everyone who is obese to go ahead and get checked for any thyroid dysfunctions?
Well, your question is, should we do screening?
Yes.
For thyroid, and I think this is the subject of the main talk of today, from the man knowing is the receptor. And well, let me give you the guidelines, and I'll make you the a judge of this, is that for instance, the European guidelines suggest screening all patients with obesity with thyroid function test with TSH, okay, and then TSH is abnormal, then they go for 3T4. The American Thyroid Association, they advise to do a screening with TSH if the patient has some symptoms, feeling tired, feeling fatigue. So they go by symptoms. There are symptoms geared guidelines. If you go by NICE also, they go by a little bit of symptoms, or if the patient has other issues like above the age of 35, if they have atrial fibrillation, like irregularity of the heart, if they're feeling tired and fatigue, they also go for and they advise for TSH assessment. If you talk about the U.S. Preventive Task Force, they take a neutral position. They don't advise against or for screening for thyroid function test.
Okay, that is pretty clear right now. Thank you so much, doctor. So somebody is asking if the anti-thyroid antibodies in the body is high. Is
Yeah.
there anything that they should do about it?
Okay, that's a very good question and really very commonly seen. You have to keep in mind that 5 to 10% of the general population, if you do testing on them, they are completely normal. Their thyroid looks normal. This is a normal finding from doing lab tests. Okay, they will have abnormal thyroid antibodies. So the presence of thyroid antibody by themselves are not an indication of an underlying pathology. Okay. Now, where the issue comes, if you have like abnormal thyroid antibodies, like you have positive thyroid antibodies in the blood, and repeatedly maintained, like if you repeat the test and they are there present and they increase in the quantitative assessment, the number goes higher, and they do show changes in the thyroid when you do thyroid ultrasound. Now, and despite the fact that the thyroid indices are still normal, this is an indication that ultimately, okay, that might your patient might get into having some maybe underactive thyroid. The presence of thyroid antibodies is persistent. There is a 4% increase in the risk of having underactive thyroid per year if the thyroid antibody kept to be persistently elevated. No, the how to address it is based on the patient symptoms and the findings on when we do the blood test. If your thyroid indices are normal, like you do 3T4, 3T3, and then or 3T4 and TSH, and they are normal, okay, and the ultrasound is normal. Normally, I don't advise on any medication to take. What I advise on is some lifestyle changes. We know that those antibody could be a marker for thyroid changes, inflammatory changes in the thyroid. So anything that really can cause changes in the inflammatory changes in the body, like either resorting to what we call anti-inflammatory diet, like either the Mediterranean diet, cut down on the carbohydrate. People, we have noticed that to have lactose intolerance, like if you take cow milk, animal milk, and they do feel bloated and then feel distended, those that probably have lactose intolerance. So we ask them to avoid having milk and milk product, animal milk, and to take like the vegetable type of milk, either coconut milk or almond milk, because that might be an added element. The other thing, we notice a good portion of those patients, the triggering mechanism could be a gluten intolerance. Like if they consume bread and the protein that in the wheat sometimes cause some inflammatory changes in the body, that not only your bowel get affected, but also the other element in the body, like the thyroid, could be involved in the process. And that's another reason to check for blood tests, to check if they have gluten, what we call sensitivity, or they have underlying problem with malabsorption, like difficulty absorbing iron. They have all the time, iron is on the low side, or and they have what we call celiac disease. So it's a screening process that we do based on what we see clinically and by taking blood testing. Another element here is that we have noticed a lot of inflammation within the thyroid recently, and then we believe has been mainly through the introduction of the iodination system of salt in UAE, which started in 2013. Before 2013, with the salt, the iodine was not added to the salt, and the reason was it was added because iodine deficiency also is a risk in the underdeveloped countries because it causes goiter formation, it causes derangement under active thyroid, and on neonatal screening, it's essential that the mother would receive enough iodine during pregnancy to avoid what we call cretinism and hypothyroidism at birth. So since the initiation worldwide, and this has been pushed by the World Health Organization, the introduction of iodine is felt to be, the iodine by itself isn't causing the inflammation within the thyroid and causing by itself the changes that we see now with more underactive thyroid gland.
Thank you so much, doctor, for the thorough explanation. Now, what if somebody has high anti-thyroid antibodies and they have other findings, for example, nodules in the thyroid, or like once they do the ultrasound, they find some kind of inflammation. Does that mean they need to be observed regularly?
Yeah. Now, again, the presence of, you have different changes within the thyroid. Nodules by themselves could be related to the inflammation within the thyroid gland, could be independent. So we have criteria to define whether those nodules are what we call of low risk, intermediate risk, or high risk, irrespective of really what we believe. I mean, whether it's low, intermediate, we have to judge this patient has low risk for having thyroid cancer, intermediate risk for having cancer when they have thyroid nodule, or high risk. And on that basis, this is how we decide whether a biopsy is needed or not. Okay, now, nodules sometimes formation is normal within an inflamed thyroid gland. It could be part of the inflammation itself. If the thyroid is felt still to be secreting normal amount of thyroid hormones, okay, there is no indication to say that they need to start on medication, except for the preventive things that I told you before that you could take in changing your lifestyle and changing your daily habits and basically carrying a healthy lifestyle. So there is no indication. Where the issue comes, if you do your baseline thyroid indices and your TSH, for instance, is high, and that's where what you need to do. And in that case, then we have to see the guidelines indicate that if your TSH is less than 10, there is no rush to give medication unless the patient has symptoms like feeling all the time, fatigue, constantly fatigue, and they have weight, excess weight, and you want to give them a trial, then you can go for start them on medication. Otherwise, we can watch them again. We also always emphasize the addition of elements that are very important for the functioning of the thyroid, like selenium, zinc, vitamin D. Those are healthy stuff that we advise to maintain in your own addition to your diet as a supplement that can help the status of the thyroid. I hope I answered the question in a way that is understandable by all.
Yes, doctor, very understandable. How about if there is the nodule and then the blood tests are normal, no symptoms, can that be unchecked? Or if there is a nodule, then that should be taken seriously without the
So,
symptoms, if
okay,
there's
if you
this
have,
finding.
yeah, if there, what you're saying, if there is a nodule, right,
Yes.
and you're obese or and in general.
So let's say no symptoms, just the nodule, and then the anti-thyroid antibodies.
Yes,
No other symptoms except the inflammation.
yes.
Um, there is no need to get it checked again.
Okay. The importance here goes to the nodule itself. The antibodies are not relevant in this case. Okay,
Okay.
that's as I told you. The nodule by ultrasound, we have to define based on criteria we use when we do the ultrasound. We classify the nodule in different categories, as I mentioned, and we go from, let's say, we go from category 1 to category 5.
Okay.
Based on the classification that we do, we can identify this nodule is a low risk. So low risk, we don't need to do anything. We'll watch it. And we
Okay.
advise for the thyroid the same as we do for anyone who doesn't have thyroid nodule. Like in that case, we advise selenium, zinc, and then lifestyle changes. If the intermediate and high risk, then we have to do biopsy, and biopsy is essential and based also on the size of the nodule. Not all nodule that intermediate and high need to have a biopsy done.
All right. Pretty clear. Now I'm going to move to another question, which is completely different. Can any issues with the thyroid, any kind of dysfunction, lead to like let's say stress, mental health issues, any kind of mood changes?
If the secretion of the thyroid is functioning normally, or if there's abnormal
If
thyroid
there's any
function.
kind of dysfunction in the thyroid?
Of course, underactive thyroid, like if you have underactive thyroid, that affect a lot of things. It can cause depression, it can cause mood changes, constant fatigue, constant tiredness, cold intolerance, change in bowel habits. This is really quite obvious. I mean, if you have underactive thyroid gland, if you have overactive thyroid gland, it causes actually the reverse. You can have some people do have increased irritability. They get angry very fast. Their behavior is uncontrollable at work. That can really affect them very badly if they have underlying psychological issues. Added to the effect of the thyroid hormone, they can lose it. Some people lose jobs because of the changes that they have in thyroid condition. So obviously it does affect mood. It affects your energy level. It affects your functioning on a daily basis in whether it's overactive or underactive thyroid. This is really obvious and present. And I can tell you one case, actually, when I was in Canada, actually, I was witness on that case. It maybe sounds really weird, but I was this lady that was, to start with, before it getting overactive thyroid, she had some underlying psychological issue, and she became overtly overactive thyroid gland and unnoticed and by the physician. And then she had one baby of 3 months, and then she went over the Niagara Falls and threw her baby over the bridge because she had uncontrollable behavior, and that was really went in the news, and there was difficult issue. They do abnormal thyroid function tests are causes for increased car accident because sometimes they becoming so hyper, and then so this is really affect your daily life if not really addressed properly.
Thank you so much for sharing this, doctor. The story, doctor. It makes it very relatable for everybody else. Um, Let us move forward to the next question, which is about whether or not thyroid disease, whether or not it's common in certain age groups or gender, for example, women or men, or whether it is something that we inherit, whether it is genetic. So these are more than one questions, but I put them together.
Yeah, they're very relevant questions, actually. To start with, yes, there are thyroid dysfunction seems to be more common in women. And the reason why we believe that probably the hormonal secretion, estrogen and progesterone might play a role in this, because when we do take thyroid gland and we look for receptors on the thyroid cells, there are estrogen receptors and there are progesterone receptors. So we see them more than we see in males. Family cases, yes, there are family cases. People, some have predisposition to inflammation, we call or autoimmune disease, like immune dysfunction, and that runs in families. So although it could be individualized, but there are some families more affected than other, and because of some what we call them HLA susceptibility, which is like more genetic predisposition, then when they exposed to changes, stress, or dysfunction in the thyroid gland, they are more prone to have changes on the thyroid gland. And the cases of cancer, thyroid cancer, we have familial cases of thyroid cancers, and we have identified like maybe more than one group in UAE that they have that runs in families that they have one member is identified. And when we call it the genetic process, you need to have at least 2 to 3 members involved. If you have more than 3 people involved with the same cancer, for instance, this is genetic until proven otherwise. And they have to go through genetic testing. And now it's really well, which is really good, is that G42 now give the chance, they can provide genetic testing for all UAE members, free for service. And actually, because it's part of the genomic testing that they're doing, and this is something that patients should be aware of it and maybe ask for it.
Okay, thank you for the advice. Moving forward to the next question, they specifically are asking about whether hyperthyroidism affects the heart or other organs, but let us keep it more general if any kind of thyroid dysfunction affects other organs.
Yes, what you have, let's take it step by step, okay? If we take overactive thyroid gland, because the thyroid gland are act on the cardiac cells by stimulating some specific, what we call the nervous system. So it's very frequently to see irregularity of the heartbeats, fast heart, like you see, they tell you that I have a pounding heart, they tell you I feel my heart beating very fast, and when you get close to them actually, and you feel their neck or they feel their pulse, it's really bouncing. I mean, it's very bouncing and fast because the increased blood flow from the heart. So it's a cause of in elderly, like when people, it's a cause for people have irregular heart beat, what we call arrhythmias, like the changes in the rhythm. So the rhythm is not regular and coming always at the same rate. So they have that changing rate from 1 second to another second, and then cause them to go into like failed heart and then fluid retention. This is the extreme, okay? On the we take the underactive thyroid because again it goes the reverse. Instead of having a fast and rapid heart rate, you have a very slow rate. So in someone who's severe underactive thyroid, they have what we call bradycardia. They have slowing of the heart rate, and they start collecting fluid, and then the heart muscle get to fail, and they go into what we call heart failure. So in both extreme, if extreme cases, you have the endpoint is weakening of the heart muscle because of irregularity in the heart rate and the weakening of the muscle itself, or overuse of the cardiac muscle. In between, you have either slowing of the heart rate or increase in heart rate, and then feeling of heat all the time. They feel hot. One of the things they tell you, I sweat a lot. I feel I'm at home, and people are like if you have underactive thyroid, you're the one putting the air conditioning high where everyone is saying we're freezing. If you had the other, is what you say that is the room temperature is normal and you're putting the air conditioning up because you feel the heat is generated from you.
Okay, thank you so much for making it really clear and for taking it into different steps. A lot of people are asking about Monjaro and the other one, Ozempic. So there are different questions that are asked in different ways. One of them is saying if they have been taking Monjaro for a year and they already lost weight, when do they know when they can stop it? And another one is saying, when is the right time to give a patient Ozempic
Okay, Ozempic or Mounjaro.
or Manjaro in general for weight loss? Yes.
Yeah. Okay. Well, let's go with the indication first. Okay, for either one. Okay, the indication is one is really when your weight has exceeded what I mentioned, like you became obese, like and you have difficulty losing weight, and those BMI is more than 30. Although now we're seeing people using it even for lower BMIs, like between 25 and 30, for different reasons. But one thing is to keep in mind that we have to rule out the family history of thyroid cancer, okay? And the other one, make certain they don't have gallstones, okay? So anyone who's obese, had fatty liver, has some tendency to become diabetic, or have pre-diabetes or diabetes, have high lipid profile, had fat accumulation in the liver, those are really good indication to start someone either Ozempic or Mounjaro. Now, if you have been on GLP-1 analog, which is Ozempic or Mounjaro, and you have been using it and you achieve a certain good results, unfortunately, we have noticed that if you stop your medication, the weight gain, you're going to regain the weight again. And the way we are, and now we believe that it's coming to the stage where obesity is a disease, is an inflammatory disease, and it's well established now as an entity by itself. If you have hypertension and you take medication for hypertension, you don't take it for only 1 month, 2 months, and then you stop the medication. It's a long-term medication. And then diabetes is the same. So we believe obesity is getting to that stage. At this moment, at this stage, we believe that this is something that those injections might be maintained for a longer period of time. And the way I advise them is really actually, rather than being on a weekly basis, to start weaning themselves. Like instead of taking it every week, they can take it every 2 weeks. And then to guide themselves based on the appetite sensation that they have. If they start feeling the appetite coming up after 2 weeks or 3 weeks, they go back to the week before. Like if they reach once a month, and if they feel that their appetite is back and they cannot retain themselves from eating, then in that case, I think they can go back to every 3 weeks or every 2 weeks. But they have to maintain it to a dosage that less than 10 milligram for Mounjaro and less than 5 milligram for Ozempic.
Okay. Would it be fine for the patient to just make these decisions, or would it be better for them to go back to the doctor? Or how often does someone need to go back to the doctor if they are taking any kind of long-term medication that affects weight or that affects the thyroid?
I think I don't think those medications have been. You can do them to do them on your own and not to have a follow-up is a little bit risky because one, your physician is being updated on really all the studies concerning those drugs and the safety on long term. Despite really the use, and so far we have had really no major results, no major side effects. But there are some cases that do happen. And I think it's concerted follow-up with your physician is always indicated. If initially every 3 months and subsequently every 6 months, to make certain that everything has been done properly and to guide you through how frequently your medication has to be changed. One thing I caution patient taking those injections is that the weight loss is not only fat, it's fat and muscle. And I've had 2 cases actually, they have severe muscle waste. So while taking those exercise is essential, and especially weight-bearing exercises, like the type of exercise, the anaerobic one that increase muscle bulk, like lifting and weightlifting. This is very important to avoid muscle wasting. I have one patient actually came unable to get off the chair because he lost so much muscle in his lower extremities. So this is something to keep in mind.
Thank you so much for sharing all of your advice, Doctor. That brings us now almost to the end of the session because of the time that we have. Since we still have a lot of questions, we will ask the attendees to send it to us through email, and then later on we will address as much as possible. Thank you once again, Dr. Khalil, for
Okay.
taking the time to answer these questions and for sharing your stories and your expertise. I would
Anytime.
like, thank you once again. I would like to ask our attendees to please scan the QR code that will be displayed on the screen right now in order to share their feedback. If in any reason you have missed part of the session, we will be sure to send you a replay in the coming days. I would like to thank you all once again for your time. Have a wonderful day, and we look forward to seeing you at our next event.
Thank you. All the best.